Hello, everyone. I am Martell Teasley, Dean of the University of Utah College of Social Work. In recent weeks, I have started many conversations and presentations with well wishes for all. And while I still offer well wishes, recent events in our cities across our country have made it clear that more is needed. Our world is churning with health concerns, social justice issues, increased violence in homes and on the streets. There's fear and a feeling of chaos. Into all of this collective trauma, social work enters. They step forward to face the challenges, to alleviate human suffering on many levels and in many places. Social workers also bring hope for the future. The problems we face today have been with us on some level for all of our lives. There is something we can do once we, as a society, recognize that something is wrong, needs to be changed, and we have the will and resolve to do it. I am confident that social workers will play a role in the change needed in our society. Today's Quarantine Talks with Teasley event is just one example of social work filling the void that may exist for many. We thank you for joining us for Isolation and Creativity in the Time of COVID-19, presented by University of Utah College of Social Work professor Troy Andersen. Dr. Andersen earned his doctorate from the College of Social Work in 2013 and his MS in gerontology from the University of Utah. A few years before that, he had earned a BA in psychology from the university and a MSW from another great university, Utah school, a bit south of our campus. Through his research, Dr. Andersen seeks to address the complex needs of individuals with Alzheimer's disease and related dementia, while also considering the needs of their caregivers. One recent project of his includes developing an app that will help guide caregivers of individuals with dementia through medical and psychosocial interventions. A second project, a collaboration with colleagues from the College of Nursing, seeks to identify individuals at risk of complicated grief as their loved ones with dementia near end of life. With appointments in both social work and the Department of Neurology and the position of Vice President at Proactive Memory Services, known as PAMS, Dr. Andersen has a full calendar. We're very glad he is able to lead this webinar today and share his experiences and expertise with us. Before yielding the virtual stage to Dr. Andersen, I want to take a few minutes to share just a bit about the series and the college with you all. Quarantine Talks with Teasley, this new virtual series, is an extension of the in-person Talks with Teasley series we initiated this past year. The name is a nod to the quarantine times we live in now. Our hope is in holding these events online, we can support our alumni and community partners with engaging presentations and free CEUs. Share some of the exciting and extremely relevant work our faculty are doing at the University of Utah College of Social Work and explore how we can better serve all of you during these exceptional times. We really want your feedback and the subject matters we're offering and your interest in online learning experiences beyond our days in crisis. We also want you to know that the College of Social Work is holding strong in this unprecedented time. You've probably heard that the U plans to resume in-person classes in the fall. The health and safety of our students and our employees is paramount as we plan this event. Last week, I had a long meeting with our faculty, and I am encouraged by the collaborative and inspiring ways they are planning for the fall semester. We just hired a new faculty member whose experience with online learning has already been an asset as we work to be creatively flexible in our classroom offerings for students, both live and in person and also remote. Over the next couple of weeks, we will be doing virtual campus visits with 3 faculty candidates to fill an open position in our practicum office. Well, that is 2 positions. We're excited about the diverse population of the professionals and the life experience of the people that have applied. As many of you know, we've joined forces with the university administration to support an emergency fund for our students. Thank you to those of you who were able to add a few dollars to this fund in lieu of the waived CEU fees. Our upcoming virtual events include 3 quorum talks with Teasley, a June 17th presentation that focuses on supporting the unique needs of seniors experiencing homelessness with Dr. Sarah Cannell. A July 9th event in which Dr. Brad Lindahl will discuss motivational interviewing. And finally, a July 23rd presentation on substance using mothers and child development by Bell Spafford Endowed Chair, Dr. Mi-Young Min. Our Community Advisory Board and committee partners initiated a 3-part webinar on telehealth. The technicalities of telehealth and telehealth techniques are available online. Our final virtual presentation in this series, Telehealth Tomorrow, will be held on Thursday, June 4th. These virtual events are all free and will be held from noon to 1 p.m. Further, we're seeking CEU approval for each one of them, and we plan to record each and offer them up to 6 weeks after the initial presentation. We hope these services to our alumni and community serve all of you well. As I've claimed since taking the helm at the College of Social Work as Dean, we are on the move, and we must stay on the move to meet the needs of our communities, from our children to our eldest friends, those of every race, creed, color, and of need. I am proud to be part of this effort and glad to have Dr. Troy Andersen on our team. Dr. Andersen is an alumni, educator, researcher, and I hear an avid cyclist who often bikes to work, bikes to the office. And he's even done that in the snow, I hear. He's also a great hope. He also brings great hope for all of us looking forward to healthy golden years. Thanks to all of you for joining us today. And thank you, Troy, for sharing your wisdom with us. Please take it away. Take care, friends.
Thank you. Well, thank you for that gracious introduction, and especially your leadership at this difficult time. You know, it's been a real challenge lately, so getting choked up a little. I appreciate this opportunity, and I appreciate the background that Dr. Teasley mentioned. Today I'll be highlighting some of my other clinical passion. So I have training and interest and expertise with older adults and individuals with dementia. The other clinical position and work that I have enjoyed throughout my career, I've been practicing about 30 years now, is working in an emergency room setting. And it is a fascinating window into the human experience. I tell my students frequently, if you want to have an excellent clinical training experience, working even part-time in an ER setting provides a fascinating glimpse into mental health and health conditions. So I'll be highlighting that in my talk today. And it's also challenging to say because, you know, often we come to these talks to get a lot of answers and to get a lot of, you know, clear-cut responses that you can take directly to practice, and I'm hoping to give you some of those. But I would say that in this intriguing time, we have often, at this point, we have a lot of more questions than we may end up having immediate answers to. But one of the things that's been fascinating of late is watching how different clinical teams, you know, individuals working in healthcare in a variety of settings, whether that's the emergency room, intensive care, in outpatient clinics, having to adapt on the fly and adapt very quickly to these changing times. So I'm going to go ahead and share my screen and get my PowerPoint slides up here. Okay, so again, the title, isolation and creativity, I think it speaks to this challenge well. And one of the primary issues to address really is this, how does isolation impact us globally, both on a health and on a mental health standpoint? One of the things Dr. Teasley mentioned, and I would highlight, is they do feel unprecedented. I've been on the planet nearly 60 years, and in looking back, I don't recall a time where it felt like the basic foundation and structure of all the things that sort of provide us solace and provide us a sense of feeling safe and secure. I don't recall a time when it's been rattled quite that way. Now, I was still a child during like the Vietnam era conflict, and then certainly all the challenges that occurred prior to that, sort of in the Great World Wars. But I think this is definitely unprecedented times. I remember in my work, so the COVID-19 outbreak was just getting started. Remember, we were trying desperately to fill our shelves with food and whatnot, and awaken to a earthquake. And I remember just thinking, you have got to be kidding me. So then I'm running out trying to fill up my gas can so that I can use my generator. And it just these, and then on all the profoundly distressing events of the last week, it just with George Floyd and all that's gone on, it does feel to me like that we're on shaky footing. And I think it's important that we think about this, how these headlines and how all of this is impacting our mental, emotional, and physical health. This was the New York Times front page on May 24th, highlighting this hallmark level of reaching 100,000 deaths in the US. I used to perseveratively look at the Johns Hopkins global map. It is fascinating to look at, but it's also overwhelming to see how this virus has spread in these incredible ways, troubling ways. And so I want to give my first poll question. I've never used poll before on Zoom. And there was love-hate relationship, mostly love, but sort of hate relationship at times with Zoom. But so I want you to answer this question on a scale of 1 to 10. How mentally and emotionally, how are you mentally and emotionally managing our current situation? So we're going to give you about just a brief moment to enter your score, and we'll see how the audience responds. I did put denial maybe for anyone that lists 10. There may be some 10s out there, but I'm certainly not one. So I'll give you a moment to do that. Okay, so we have 8 seems to be our the most selected answer, which is very good. It speaks to our highly functional audience. But I think it's very important to think, and I've contemplated this recently. When for someone of privilege, for someone who has no access problems to healthcare, to no food insecurity. It's so interesting to imagine how those individuals with vulnerabilities and those individuals who are living very close to the edge financially, how they are managing in these very stressful and difficult times. Get my slides working here again. Okay, so I'm just going to start with this idea of helping in a time of COVID. I used helping as sort of broadly. I mean, I am a team player on a team of, I'm very a strong advocate for interprofessional and interdisciplinary teams. And so I favor looking at this as sort of a team process. So here's the first picture. So imagine this. This is some of the gear that gets used in an emergency room setting. Our goal is to provide solace and support and to provide comfort and to provide some calmness to individuals who are having either health or mental health crisis. Now, I tell you what, wearing that is just overwhelming and incredibly uncomfortable. The mask makes it difficult to breathe. First time I've been able to really recognize how many times a day I need to brush my teeth as a side joke. But then all this gear, one of the things that's incredibly difficult is to attempt to communicate and to make that connection when we're in these suits. Now, there are suits that are even way more involved that the doctors have to wear with an actual oxygen source. But this is one of the unique ways in which the attempt to do this work is challenging at best. Another thing that I found, sorry, my dog's, it must be the mailman. One of the things that we found in the ER is that in working in the ER, one of the challenges is to be incredibly creative and to be well-versed in utilizing a variety of community-based resources. And these resources, as you can imagine, are historically incredibly limited, finite. Often there are few choices available for individuals who are homeless or individuals who are chronically mentally ill. And one of the things that's been really difficult with this experience is that even these very limited resources have been decimated and incredibly challenged by the COVID virus pandemic. As you can see, there's been outbreaks in the shelters. The community detox programs have had to close down temporarily at times. Often there are barriers in getting people admitted for mental health admissions or for detoxification admissions based on really needing to have a swab result back for the COVID testing. We have been challenged with that, and there have been significant improvements in the last 2 months in the turnaround time on getting those results back. There are incredibly limited numbers, though, of the type of rapid tests that can be done. Domestic violence shelters are affected, and also we've seen an uptick in domestic violence reports. And so, again, just incredibly challenging when you think about working as usual, very limited resource, and now these are strained even significantly worse. So then switching to this idea of the sort of the isolation and how that affects mental health, I have to start with my sweet story of my latest grandbaby. She was born, interestingly, right at the moment where this pandemic began to take hold and traction and expand drastically in the United States. My daughter lives in Pennsylvania, an area that's been hard hit with this virus. So she was born premature, 10 weeks early, and was in the NICU for about that time. She was about 8 or 9 weeks in the NICU. And so my poor daughter, this is her first child, is having to, first of all, she had to be in the hospital for a number of weeks prior to the birth with preeclampsia, but then after having to really challenging visitation restrictions. My son-in-law had some symptoms. He was fortunately COVID negative, but had to be 2 weeks in quarantine before they would let him come back. So this is a life, across the lifespan kind of condition as far as this isolation is concerned. But I want to just take a brief moment and highlight some fascinating research that has been done on the ill effects of social isolation. Um, I think we can think about that in kind of common sense terms of, oh yeah, isolation is really difficult, particularly again with the clientele and my expertise working with older adults. It's definitely a concern. But look at these staggering responses to this research that indicate the ill health effects of social isolation. So comparatively to smoking 15 cigarettes a day, or twice as harmful as obesity, or exceeding premature mortality compared to other well-known health indicators, 30% increase of stroke, coronary artery disease, and increased risk for dementia. And so I think one of the keynotes from this, particularly again working, now I would say that, again, I tend to look through the geriatric lens, but I think that isolation has been profound. I have 2 stepboys who have been, again, home and homeschooling, and it has been very difficult for them to be so socially isolated, and very difficult on their mental health. And so this applies to children, all of us as adults, so it's widespread. But I think this health concerns really that I'm describing primarily related to older adults. And then isolation in general, there's this beautiful, you have to Google this one after the talk, beautiful video clip of this couple, John and Ann Klein. They've been married 45 years. And this sweet man, and his wife has Alzheimer's disease, and he was a constant by her side. And he's singing well-known songs, and she's singing with him through the glass. And it makes you it's heart-wrenching to think. When you think of an individual with dementia and how difficult it is to remain connected and oriented to world in general, and then to lose the routine family-based or spouse-based visits, it's so devastating. And so then again, this couple, but then also generally I've kind of described that, increases significantly in depression and anxiety, school difficulties, not only just in isolation, but definitely troubles with having kids that have varying abilities with learning. And again, those with the most disparities are the ones that are having the most challenges. But being able to engage in complete schoolwork, I take my hat off for teachers that are teaching in elementary and middle school years, because it's such a challenging situation. Again, older adults, one of the things that we've done, and I'll talk about in a minute with my kind of creative solutions, has been to utilize technology as a means of staying connected. And often older adults are more challenged with utilizing the latest and greatest in technologies. So we've talked about dementia, but again, I think that's challenged with maintaining some connection and their connection to the outside world. And then I would say some more general practical needs, like physical needs. So my mother-in-law has ill health, and just getting basic needs met, going to the store, and she's in that high risk window, and so even just managing physical needs has been very challenging. Anxiety is significantly affected by this. One of the things that's interesting about the way that our body and our brain responds to anxiety is that we want to know the enemy. We want to know what that animal is. When we have our fight or flight response, we want to know what's chasing us. We want to know how to protect ourselves. We want to know, how can I get in a safe space so whatever that dangerous thing is will be, I'll be protected. And so when we think about how a virus is conceptualized in that context, so it creates this pervasive, circular, perseverative nature of trying to figure out, how do I stay safe in this difficult situation? And what do? We turn to various media outlets And one of the things that's incredibly challenging is that there's so much misinformation and conflicting information, and that just makes it less uncertain, which heightens the anxiety. We have incredible fears for ourselves and for our health of our loved ones. Financial worries are profound. We have the highest levels of unemployment, I think, since the Great Depression. Changes to sleep. So for us to sleep well, we have to be able to relax and get out of that hypervigilant mode. And for many, they are not able to do that. And this can have ill effects on health and mental health. For common sense reasons, so again, increased worry, but also it is drastically, and it has at least initially interfered with individuals going to normally scheduled doctor's appointments or normally scheduled therapy appointments. And so it's interfered with our already involved ways in which we've been able to manage our health conditions. And then finally, the risk factors for increased alcohol, tobacco, or other drug use. Again, I always kid a little about, challenges of, how do you manage alcohol use when you retire? Well, this has been sort of thrown us all into that mode where all of a sudden we've lost our routine, we've lost our schedule, we've lost those things that sort of create that routine of our day, and it can really be disorienting for us. Again, I'm not going to spend a lot of time with this slide. You got off, these are common sense situations, but I think it's helpful to look just about how this affects us both on our behavioral, physical, emotional, and our cognitive changes. Increased irritability and worry, which can lead to changes in appetite, feeling frustrated and angry. Our brains do not work well when we are in that panic mode. We basically are concentrating on fight or flight response, and so it makes it difficult for our normal cognitive capacity. So this is just common sense ways in which we have that stress cycle where we see the ill effects both on our health, our physical well-being, whether that's temporary, like getting too much stomach acid, headaches, changes in sleep patterns. So these are all commonly occurring things. So some basic stress management skills, again, these are common sense, but some that are specific to COVID. I really think it's critical to manage how much information we're taking in. And it's so difficult because when we feel anxious, we want to figure out what the threat is. And so our brain is drawn to more information. But what we're left with is being constantly overwhelmed. So one thing that I would definitely say is we want to manage when we consume our information. Definitely not in the evening. We want to be a 90-minute preparation for sleep that does not include any inundation with issues related to all the stressors that are going on in our world right now. The second one that's difficult is maintaining a routine. I think, how do we, we talk to friends and there's jokes on Instagram about, I've been in the same sweats for, 4 days. But I think it's important to try to develop a new structure. So that might be, again, getting up, taking a shower, getting up at a specific hour, taking a shower, creating that structure within this kind of time when structure has been thrown on its side. I think finding some ways to relax, that's been challenging with being indoors. One of my favorite things to do, Dean Teasley mentioned cycling, and my second or favorite thing is to go on long hikes. And I think just the difficulty with being isolated in the home, very difficult. I think it's been difficult on our diet. I think we've have to resort to food delivery and maybe fast food delivery. But I think those are difficult things too. And then this sort of time to unwind, I think, again, particularly in the evenings. And then finally, finding ways, and I think this has been a beautiful silver lining of this experience, is that I think we found a variety of different creative ways to stay connected, although there still doesn't really replace getting a good hug from someone that you love. So I want to just briefly run through this kind of dialogue kind of question. So in the ER, I teach DSM, and in the ER, our jobs is to make diagnoses of individuals presenting to the ER. So historically, if somebody came in, they said, I am completely freaked out and worried about contracting this infectious disease. I'm perseverating about the well-being of my loved ones. I'm worried about the end of the world, and I'm worried about the survival of the earth as we know it. So if you were to encounter that in a mental health evaluation prior to this pandemic, we might think, if we look at our DSM, we might think, does this person have illness anxiety disorder? Do they have separation anxiety disorder? Do they have some type of paranoia? And so we've gone from things that would be historically maybe, obviously those wouldn't be enough to make the diagnosis, but we've gone from things where these seem to be outliers, and these seem to be things that we might consider to be attributes or symptoms of a mental illness problem, to being what I would say a normative stress response. And it does speak to the way in which our world has changed. And having to really adapt and alter the way that we look at these things. All right, so let's talk a little about the healthcare impacts. I found a few very interesting and unusual examples of personal protective equipment. You do the best of what you have. These are not particularly effective. So we'll talk about, and this at this time, and this is probably very familiar to all of you at this point, because there has been, if we go to the right sources, there have been some accurate and clear information about health risks related to COVID-19. Certainly, and primarily individuals in the 65 and older category are at the most risk. Individuals living in residential settings, nursing homes, assisted living, long-term care, very much at risk because of the proximity and of there, and we'll talk about that again in a minute. Anyone with any underlying, and this is a long list, don't need to go them into much detail, but there's a long list of a host of immunocompromising illnesses and even medications that can put someone at heightened risk. Certainly anyone with any kind of pulmonary disease, asthma, respiratory diseases, heart conditions, involved in any type of cancer treatment where, again, they're immunosuppressed. And then normal sort of chronic health risks related to diabetes and kidney disease, liver disease. So these are individuals that are really at heightened risk. But again, as we've learned with this, what they call it a novel coronavirus. This has unique manifestations that we're still learning about on a daily basis. So, but these are the ones that are most notably at risk. There's also some shocking and concerning and very troubling disparities, racial disparities. That NPR has done an analysis that African Americans are dying of this 2 times greater than would be expected based on their percentage in the population. Hispanics and Latinos also much higher risk. This little graph, it's hard to see, it's small, but this was a graph that was depicting the different parishes in the New Orleans area. And you can see that the ratios of deaths there are just shocking and very concerning. And I think they're still trying to figure out what might be the primary reasons for this. But it speaks to the disparity of response in a troubling way. Another challenge in the healthcare setting is that we've had to really adapt the entire healthcare process, particularly in a hospital setting. Protocols change nearly every day. We've had to create COVID-specific sections in the ER, and that's where we see people wearing these hazmat suits or PAPR suits, where you imagine trying to create that connection when you have to wear this equipment. And imagine the stress of having to wear this equipment for a 12-hour shift. My hat goes off to colleagues of mine who So in the ER, social workers are not real, or semi-frontline, but the doctors and nurses, respiratory therapists are truly encountering individuals with COVID positive symptoms on a daily basis. They've had to reallocate staff. Most of the elective surgeries have been postponed, which has been having to just shift. And, you know, hospitals are healthcare facilities, but they also have a business aspect. And so it has had a financial toll on healthcare systems. So it's been a very difficult challenge kind of adapt as we went along. I think probably from the social work perspective, and one of the things that I would highlight here is that there's been drastic changes to visitation and communication. One thing I mentioned to start with in that picture was the ability to communicate with personal protective equipment is very difficult, as you've seen in several pictures. But one of the things that's very challenging when you're talking to families is they hear on the news, you know, that we need social and physical distancing, but it's so stressful to say that to someone whose loved one is in the ICU or comes in as a trauma patient. To say to them, we're sorry, you cannot enter into our emergency room. You cannot enter into the intensive care unit. Imagine your son or daughter or your mother or father, your spouse is brought in with either COVID-related symptoms and needs to be intubated, comes in as a trauma patient. You sit in the parking lot. You wait for phone calls to give you updates. You're not allowed to be able to be at bedside and provide calming support. So on a logical level, people could say, oh, that makes sense that we want to protect everyone. So basically, we're trying to avoid, these restrictions are based on trying to avoid visitors coming and getting exposed, but also primarily visitors bringing in the infection to a highly vulnerable population. You know, talked about long-term care, but hospitals are the same way. Lots of vulnerable sick people. And once the virus gets embedded in a hospital setting, it can spread around quickly as well. So this, for me, one of the most challenging things has been having to be the liaison, the go-between with the family and the medical team, being able to provide as much information as possible, provide as much comfort as possible, all the while being this face that says, no, you cannot come in these doors. And families it varies, but they can get very upset, as you can imagine. And again, I'll talk about some of the creative ways that we've been able to improve communication. One strong take-home note I think is very important is that if someone does have a critically ill member in the hospital, very important for the family to organize around and have one primary contact person with that hospital staff. These staff are incredibly overwhelmed currently, and so we don't want a family of 12 kids, all family members and cousins and nieces and nephews calling the nurse and saying, how is grandma and grandpa doing? They need to have a structured way in which that information flow is coming and going through these means. Okay, so I want to take another quick poll. I got to keep track of the time. Got to move along. So quick poll. How many individuals in the U.S. have an advanced healthcare directive? I feel like I need to make that Jeopardy sound. Give me a chance to get a little water. Okay, answer says? Okay, so 56%, I see, 14% is not correct, 37% is correct. Okay, so you're in the ballpark, leaning toward not many having it. So that's sort of the answer that is of concern. So, so 37, so basically a little over one third of individuals have an advanced healthcare directive. So one of the things that's been incredibly challenging with COVID is end-of-life conversations and goals of care conversations. So we have the quarantine, again, no visitors. People with COVID are often dying alone. The key part here, and again, the social work role might be that, that if those individuals have not had that conversation, these conversations are incredibly difficult because individuals can deteriorate very quickly of respiratory distress, respiratory arrest, and these decisions have to be made in rapid fire succession without being able to have the face-to-face conversation often. And so this has been another challenge as to how do you have these conversations. So I want to highlight really quickly, because I know I always get talking too much and get running short on time, but example, 84-year-old gentleman, families in the parking lot, trying to find a way for the physician to talk to the family about choices that are being made. The patient is just about to be intubated. So in our creative sense, we've tried to use iPads. So the doctor has the iPad. The sad thing, and unfortunately is, of course, as luck would have it, the individuals have Android phones in the parking lot. They don't have Apple phones. And so in a creative fashion, we had to grab an iPhone for the doctor, take the iPad out to the parking lot, have a conversation while the doctor is all suited up in the PAPR outfit about what do you want us to do with your 84-year-old dear father and loved one, and how do we manage his care from this point forward. But I gave that as a brief example, and that's a true story, but this is happening on a daily basis. This is not a uncommon experience. This is happening consistently. You see this tragic picture of nursing staff trying to communicate with family members who are outside. I want to speak briefly again to the issues related to COVID and long-term care. This is an area that's been decimated. A third of all deaths have been in long-term care facilities. This is breaking news and tragic news. The Veterans Home long-term care facility has recently had an outbreak, and I think in any setting, but in this long-term care setting, where they're there and they deal with chronic health conditions beautifully, are thrown into this acute care nightmare, and they've had staff and residents testing positive. Once this starts, it's an absolute nightmare. And just hearts and hats go off to individuals working in long-term care, because it is so unbelievably challenging. Let's talk briefly about the grief and loss experience. This has been devastating because, again, like I've already mentioned, the death can happen quickly. It can happen very unexpectedly. No visitation at end of life, but also it hampers the ability to do funeral planning and to do normal funeral situations, postponing burials, affecting cultural traditions when it comes to death and the burial procedures. This is, and again, I use this example from New York. Now, this is not meant in any way to demonize this story, but it speaks to how incredibly challenging when New York's had tens of thousands of individuals dying. They have nowhere to put the bodies. And can you imagine having your loved one die, not being able to see them, not knowing where the body is, they found bodies in a U-Haul truck. And again, not meant to say that this is just a story, but it speaks to how incredibly challenging and how they've had to be. We don't have plans for this. We don't have means to deal with this. And I just say that, Dr. Teasley mentioned that I work with Dr. Kathy Supiano, on issues related to complicated grief. And this certainly would put people at higher risk for complicated grief because of this multiple level disruption. Okay, let me talk about creative solutions. Let's see, we're doing time-wise. Oh, we're getting really close. Okay, so one of the advances that's taken off, and again, I think telehealth and mental health has been practice, but I think that the COVID experience has really sped this up, and I think it's sped up legislation around it. The silver lining here is that it hopefully will create new billing codes, new ways to make this more accessible. There are millions of Americans with limited access to mental health care in frontier and rural areas. And so the hope is that as this technology makes it creative advances in this era, that will continue. There have been creative ways. So they started, interestingly enough, one of the examples of a creative answer is they started using baby monitors for families to be able to have a baby monitor for their loved one that's in the intensive care unit. Now, again, these are not without challenges, because that requires the already overwhelmed staff to participate in making sure that those things are working. We've also made sure, one of the things we've made sure is that if a trauma patient comes in, we make sure that they have their cell phone available with them, because then they can do FaceTime with their family as they recover. And it's been another way that we've used this. So there are a variety of advances that I think hopefully will continue to gain traction and become more, well developed. One of the things I'd say briefly, and I got to move on, is there are no protocols or limited protocols for doing a lot of these virtual healthcare visits. And this has forced us to be able to speed that up drastically. And so one of the things that I would suggest, and I'm not sure exactly how these slides will be available, but I think it's very important to have a structured template that we would use in a healthcare or a mental health telehealth visit. So it's different from the usual, encounter we might have. And I think having a structured template that is more universal that we might use in a clinical setting is a really good example of an advance that has occurred within this time window. Okay, one more participant poll. Let's do this quickly. What percentage of older adults routinely use social networking? Answer says, okay, so good, you're right, close. So 27% is the answer from this poll. It's a Pew poll, Pew Research poll. And so the main point I bring up with this is to highlight the fact that just because we've made advances with technology doesn't necessarily mean that it's an answer for all. And so there may be limitations to this. One might be comfort with using technology and comfort with using social communication tools. Another thing that can occur, and I've done some work in on the reservation in Southeast Utah, is that even access to online access can be limited. So I think it's important to think about the fact that, just because these advances occur, they're not a one size fits all. So I want to just end with challenges. Again, I've kind of talked about this, I don't really spend too much time, but in watching the situation in New York occur, there have been, worldwide, there's been an estimate that there's been 90,000 healthcare workers who have been infected with coronavirus or COVID-19. There are significant, you can imagine every day, just that worry of every day I go to work, I'm exposing myself and potentially my family. There's been a significant, and I'm not going to go into this in too much detail. They had mayors from around the country respond to questions related to having appropriate levels of equipment. And these numbers are very concerning and staggering, that really, we lacked preparation, and we lacked a lot of these basic equipments that, I think about the N95 masks, which are the most effective. Those are, they sell for I don't know, making it up, 25 bucks a piece now, because again, they're so scarce. Ventilators have been a significant resource that's been very limited. And that's one of the things where they say, planning for surges. Oftentimes people associate is a surge over related to, I can run out and go to Lagoon now? And really it's gauged more on, is there capacity in the intensive care to care for those who are infected and becoming sick? And so it doesn't really mean that all's well. Okay, so I want to just summarize, and then if we have a few minutes for questions. So this has been a truly, again, I can just speak for my lifetime, unprecedented for me, lived experience to see this event that has altered the global lived experience. And I think that's true throughout the corners of the world. There's been obviously increased global isolation, lots of health-related impacts, lots of end of life. We've covered this. I think the thing for me as a final take-home is how might this change us in a positive way? I think that we'll find that there will be silver linings, and that there will be ways in which we might prioritize our time in our life. We might find more effective ways of doing maybe meetings, or some other ways in which we find, hey, we don't really have to all be at the same place. So, and ways to use innovation. So again, we got 9 minutes. Emily, I don't know if we have, let me just stop sharing here. I don't know, as far as questions, let me see if we've got. So we're just looking down the list. Brad Lundahl, hi Brad. Pain of isolation, thoughts on solitary confinement. Boy, that's another talk. I'm always cautious about expressing my unfiltered comments because I don't filter well. But I often view, particularly for those who have mental illness, but even broadly, I think solitary confinement is torture and torturous. And I visited the prison, and they had a special unit where people with chronic mental illness were housed. And I think I think we're learning about. I think this broadens the lens to a broader population, that so makes that more clear. But I think it's a critical question that hopefully will get addressed, because I think it's really do torture us from a human perspective. Let's see if there's any other questions. I do have, now again, I think with the slides, I can't remember if anybody said that. There are, I didn't actually go to the last slide, but I've listed, and there's a whole long list of creative resources that I've included that you can peruse. I didn't have time to cover all these, but I tried to find a variety of different interesting examples that could help in a variety of different settings, whether that's mental health or in a healthcare setting. Someone said adjustment disorder. That's a good answer. I think that would make sense.
It looks like we've got a couple questions coming in through the Q&A feature.
Okay,
You want to check there?
Okay, let's try that. Okay, so one question came in as the sort of normative stress response. This is interpreted as mental health or emotional illness. Is there a danger of having or developing chronic mental health or the like because of the new normative stress responses? I would say yes to that. So I think that, but I think the greater concern for me is the exacerbation of individuals that have existing mental health problems. I think that that it'll be interesting to see if there is if we get who says what's normal again. And so I don't know with our new normalcy whether we'll see just heightened senses of anxiety. I think generally in our world right now there's so much unrest and stress that I think anxiety is becoming far more common. Have we seen an influx of people pulling loved ones out of skilled nursing facilities? I don't know. It's an interesting question, but the challenge with that is that most families wait until the very end to even bridge that concept of like having a loved one in a skilled nursing facility, and it's based on the fact that they cannot care for that loved one. And so I think that may be more the case maybe with assisted living, but most people don't enter that unless there is an incredible reason why they cannot be cared for at home. So that's a great question. So how do you believe COVID is impacting stabilization efforts of clients who present in the ED in crisis? I think it's making influx. I think it's much more difficult to use the normal sort of centering and calming approaches. It's much more difficult to say, what kind of things can you turn to in order to reduce your stress, because those choices are now restricted and limited, and the fears are real. And so I think it makes it much more difficult. And again, there's a list of creative resources. Yes, they're on the last slide. I didn't show you that, but Emily, I'm hoping we can find a way to share these slides. Has there been an increase in the amount of creativity among expletives? Oh, wait, make sure I get this right. I'm not sure I get that one. Sorry. As told in St. George Hospital in my area, that COVID patient, Hispanic woman, was put into a curtained off room without bathroom, rarely visited. Boy, horrible. I think, I think if we, so again, my caution in, I don't know anything about that story. My caution is answering questions like that, but I think that skilled nursing facilities are pushed to the brink of these are in industry that was profoundly overwhelmed and under-resourced for decades, and this has just decimated that whole situation. And so it's so upsetting when you hear these stories, and but it's also so concerning to say, how do they solve these problems, these incredibly difficult problems? So great questions. And just really difficult times. Thank you all so much for joining in. I much prefer, if in usual lived experience, that we have that face-to-face, see you, have interaction, but this is, again, the new world. And I just appreciate you taking time today, and it's been very enjoyable for me to participate. And again, unfortunately, I'm leaving you with probably more to think about on the challenges than I am to think about on fabulous solutions. But that's one of the joys and the beauties of social work, is that we tend to be incredibly resourceful and creative at solving impossible problems. So I'll leave you to go back to your lives and continue your good work.